We finally did it, guys. We got to the end of the upper extremity here. We're at the wrist and hand. But you may be asking yourself, Matt, why do we need to know this stuff? Don't we just send anybody with a hand problem to a certified hand therapist or anybody with a hand problem to occupational therapy? No, no, we don't, you guys. Don't give away your patients. Come on now. Sometimes it's nice to be able to refer to those people if you have somebody that's a little more advanced than what you've seen. But you guys should know all this stuff because if somebody were to come in and need you to treat them and you're the only one around, you got to be able to do this. And your board exam loves questions on the wrist and hand, particularly in the zones. So if you haven't reviewed those in your book, I would highly recommend it. But let's get it going. We're going to start by looking at the structure and the function of the wrist and the hand. So when we go and look at the joints of the wrist and hand, you know that there's a lot of bones that kind of go in there. We got about 27 of them. We have 27 bones in the hands. We have a ton of ligaments for stability. You can see how many ligaments there are. There are a lot. I can't remember all their names, but there are a lot. You kind of look at where they go and try to guess at how many there are. And so what we know is the wrist is basically on an oblique axis. And so what I mean by that is as you go into wrist extension, you'll notice your hand goes into radial deviation. And when you go into wrist flexion, you'll notice that we go into ulnar deviation. That's kind of like when you throw a dart, you'll see people go into that same thing. We have our concave radius on our convex carpals, and so the slide is going to be opposite of where the physiological motion goes because we have convex carpals moving on our concave radius. So as we go into wrist extension, our proximal row of carpals are going to slide palmarly, and so we have our slide in the opposite direction of the motion. Important to know for when we're doing our mobilizations. With the ulnar compartment, right? We have our capitate and our hamate. As are both, the hamate is convex on the scaphoid, on the lunate and the triquetrum. Those are going to be concave. So the capitate, hamate, convex, scaphoid, lunate, triquetrum, when they're combining, make concave. So again, we got convex on concave. We're going to have slide opposite to the motion that we go. On the radial compartment, we have our trapezium and our trapezoid, which are concave on our convex scaphoid, which means we're going to have the slide in the same direction. During radial and ulnar deviation, the rotation is basically occurring in the scaphoid. And with our radial deviation, our volar side is going to flex, and we have about 15 degrees of that. And then ulnar deviation, our dorsal side extends, and we have about 20 degrees of that. So this is why people are like, oh my gosh, it's a lot of numbers. How do I remember it? Part of the hand does one thing, part of the hand does the other thing. This is why people give up on the hand because it sounds so complicated. But it just kind of follows your articulation rules as you have seen before. You just have to be really good on looking at your anatomy going, which side is convex, which side is concave of each of the proximal row and the distal row of carpals. So I challenge you to get better at looking at those things. I already talked about those, so man, I am ahead of schedule already. Woohoo! All right, moving on. We're going to be looking at the characteristics and arthrokinematics of the CMC joints and of the two CMC joints of the digits 2 through 5, and then the CMC of the first one. So with the carpal metacarpal joints, they're highly stable, and 4 and 5, so the metacarpals 4 and 5, have convex bases on the concave hamate. And the reason they do that is looking for increased mobility. So you can kind of see this, right? As you bend in your little finger and your ring finger, you're going to notice that there's a lot of motion coming towards the center of the palm. And the reason we want that to happen is it's actually going to functionally increase your ability to grasp rather than coming straight down, kind of like your index and middle finger will do. So we have more motion at our fourth and fifth finger than we do at our second and third finger in order to improve the grasp. We have our concave proximal surfaces that are going to slide volarly on our convex carpals with flexion and dorsally with extension. So depending on what you're trying to mobilize, you can remember how to do that. Now when it gets to the CMC joint, now we get a little bit more fun. is a saddle joint. So remember, part of it's going to be concave on convex, the other part's going to be convex on concave. So within the saddle joint, the trapezium is concave in the dorsal and volar direction, but convex in the radial to ulnar direction. So when we do palmar abduction with the thumb, abduction, and when we do adduction, we've got convex on concave, so our slide is going to be in the opposite direction of the physiological motion. When we do flexion and extension of the thumb, now we call that the radial abduction and adduction. It gets a little crazy, but that's going to be, when we do flexion and extension, we're basically going to have the same side with the physiological motion because we have concave on convex. So what does that look like? If you don't remember the positions of the thumb and the motion, this can get very confusing. Flexion is coming across towards the center of the palm. Extension is going further away. Abduction, if your hand is in that position, your thumb is coming out towards your face. Adduction is you're going pressed up right against the finger. And then opposition is bringing your thumb to your little finger. So maybe review the mechanics and the motions of your thumb, and that will help you figure out, is this convex on concave? Because you will see a lot of folks that have thumb injuries, particularly if you're looking at trying to work with athletes later on. There'll be a lot of thumb and finger injuries. I've worked on so many fingers, from particularly goalkeepers in soccer. They just end up getting all these busted up fingers, and we'll talk about what I actually see in the clinic when we get down there a little bit further. When we get to the metacarpal phalangeal joint, so the MCP portions, we have the condyloid has bilateral joints. It's kind of shaped like a biaxial joints, not bilateral. That'd be weird. They are bilateral, but it's biaxial, so not uniaxial, biaxial. It's kind of shaped like a cup. It allows for flexion, extension, and abduction, adduction. And the reason we want that is it's going to be able to, when we flex and get to abduct, we're actually going to increase our grip strength. So we have, it's controlled by kind of a volar plate and two collateral ligaments that are going to be taut in flexion to help prevent abduction and adduction. And with our arthrokinematics, basically it's that concave on convex. So we're going to have our rolls, and our slides going to be the same direction as the physiological motion. When we get further down the hand into the IP joint, the MP of the thumb is different because it has two sesamoid bones on the volar side. If you remember, sesamoid bones are there to kind of help increase the pulley on there, and what that helps with is it helps with the flexor pollicis brevis activation, having those two sesamoid bones of the thumb. The collateral ligaments remain constant throughout the range of motion, trying to prevent that abduction and adduction. We have increased range of motion as we move from the radial to ulnar side for flexion and extension, and the reason for that is towards the ulnar side, we need the opposition of those fingers to try to get to the middle of the palm for increased grasp. And again, we have a concave on convex, so we have we still have the same slide in the direction of the physiological motion. That sounds like a lot of stuff, right? But fortunately, your book has some good online references for you. If you log on to the book's website, you can go to box 19.1 and it will review all those motions for you. There's also some pretty good YouTube videos out there if you need more of a visualization. Oh man, I'm flowing right now. Excellent. All right, moving on. When we get to the function of the hand, we know that the key with this is really having that length-tension relationship in order to maintain a good grasping mechanism. That's what we need our hands for, picking things up, right? We have an extensor mechanism, and then we have the control of the unloaded free hand, kind of allowing for more precision, things of that nature. So the position of the wrist is really going to control what the length of the extrinsic muscles of the digits are. So as your finger flex, our wrist extensors stabilize to keep the wrist going into flexion. And the reason for that is you're going to be able to increase your grip strength and with more wrist extension. So you can kind of see this for yourself. So try to bring your fingers and flex your fingers down to your palm as close as you possibly can. Now what you're going to do is I want you to relax. I want you to put your wrist into full flexion and then do the same thing. And you notice it's a lot harder to get your fingers to your palm, and you can imagine you're going to have a weaker grip there. Now let's reverse that. I want you to go to full wrist extension and then flex your fingers. You know, it's a lot easier. So this is why you kind of see, if you've ever seen anybody that has a spinal cord injury, and we look for that tendinosis grip, sometimes they may not actually have the activation of the muscle of the hands to grip, but if they still have activation of the wrist extensors, they may be able to grip a few things because you get that nice passive help from the extensor tendons pulling the fingers into flexion. So that's kind of that extensor mechanism. So the extensor mechanism, if we dive into it a little bit more specifically, it's made up of the extensor digitorum tendon with the extensor indicis and the digiti minimi. It also has the extensor hood, the central tendon, the lateral bands, which are stabilized by that triangular ligament. The more passive components of it, right? So ligaments don't really have contractibility stuff, so your passive components are going to be your triangular ligament and your sagittal bands, which are basically trying to prevent the bowstringing of the tendons. Your active components are going to be that dorsal interossei, that volar interossei, and those lumbricals. Those are the key muscles of the hand that kind of really help with grip, that are more the intrinsic portion. And then we have our active extensor digitorum, and basically what that does is, the way that it ends up attaching, it can put tension in the sagittal bands, pulling them proximally, which leads to the extension of the proximal phalanx and the MP joint hyperextension or the IP joint flexion if it's from passive pull from the flexor tendon, which can lead to that kind of claw or hook position. Again, I know this is a lot of words. Hopefully you've already read the chapter and your book does a really good job of explaining these things. I'm just trying to hit you again with them because sometimes it could be a little bit confusing. So continue on with the extensor mechanism. When the PIP, that proximal interphalangeal phalanx, extends, so does the DIP. So and that is done with the interossei and the lumbrical muscles through the extensor hood. Remember, they have attachment into that extensor hood. So there must be tension in the extensor digitorum tendon for there to be IP extension. Active contraction of muscles causes MP extension concurrently through the intrinsic muscles contracted or passive tension of the extensor digitorum, which occurs with MP flexion. Again, sounds crazy, but this is why we can do different shapes with our hands to get different grips. Refer to your book. I'm going to keep saying that because it does a really good job explaining these things and has some pretty good pictures as well. And then kind of continuing on with the dorsal interossei and the volar interossei, the lumbrical, they pass volarly to the joint of the axis of the MP and insert into the extensor mechanism proximally to the PIP with the extensor digitorum. So then that way when the interossei and the lumbricals all contract together, that creates MP and IP extension. When you don't have an extensor digitorum contracting with those things, you're going to create MP flexion and IP extension. That's why we kind of have what we call the lumbrical grip, would be something that you may have seen before. So then there's several different type of grips. So I'm going to put a picture here. This is all the anatomy, right? Review that. There's your lateral bands there on the sides. You got your extensor hood. You can see your sagittal bands. You can see where the muscles insert on this. And again, this anatomy is difficult and the biomechanics are difficult, which is why a lot of people give up on hands. But when you kind of think about it if you can get this from a biomechanical perspective, then it makes it a lot easier. And actually every other joint becomes a lot easier because this one's definitely more complicated than the others. Kind of talked about those already. So now we're getting into the grips. So we have a couple different grips when we look at them. With the power grip, your fingers are going to be flexed against the palm of the hand with the counter pressure from the palmarly adducted thumb. The cylindrical grip is also considered part of the power grip. You have a spherical grip, a hook grip, and a lateral precision. All those would be considered power grips. The max amount of grip occurs with the wrist position and slight extension and ulnar deviation. We just talked about why that's kind of the case. And with the flexors of the flexor digitorum profundus of the fourth and fifth providing the major contraction of that, right? That's why we have them dive towards the center because they're the ones giving us the most. And only the fourth lumbrical participates in the power grip. That's an interesting thought when you think about all the lumbricals that we have, and only the fourth one is really participating in the power grip. Versus when we get to the precision grip, right? Precision means this kind of like pinch grip, and that's really the grip that we use when we're trying to manipulate an object that's not touching the palm. So this would be an example of like writing with a pen or pencil will be when we don't want it necessarily on the palm. We want to be able to be a little bit more precise with our movements. And so in this one, we have our interossei. Well, they're going to basically abduct and adduct the fingers to help manipulate the objects, and then the lumbricals help move the object away from the palm. So it's really your lumbricals and interossei that are working hard in that precision grip. And then we have our combined grip, which is basically the digits of the first and second digit perform precision activities, whereas the other ones perform more power activities. So again, your book does a really good job explaining these and giving you examples of when you use one grip over the other. So I would look at table 19.1, kind of outlines the muscles if you're lost there. Figure 19.2 illustrates the extrinsic and intrinsic muscles, and then figure 19.3 illustrates the anatomical structures and the extensor mechanism itself. So take a look at those if that one's a little more confusing for you. You know it's got to be hard because I've already spent over 7 minutes on this one slide. I'm sure you're so stoked about what the rest of this PowerPoint's going to look like. Alright, moving on, right? We talked about when we were in the elbow and the shoulder, we talked about the nerves and how those can kind of get entrapped at those local sites. Well, guess what? We got other sites down into the wrist and hand that the nerves can get entrapped as well. So so the basis part of this is I have a patient that's coming in. They're complaining of the fourth and fifth, so your little finger and finger numbness and tingling. That sounds like a nerve problem. I just don't know if it's coming from the neck or the shoulder or the elbow or the forearm or the wrist or the hand. I don't know. There's a ton of sites of compression for each one of these things, and I have to go through and try to systematically remove the ones that aren't there. In addition to that, we can have it depends on what the rest of the patient's saying, right? So if we think about the hand itself, we know that the dermatomes down there are going to kind of be involved with C6, C7, C8, T1. Those kind of get the wrist and the hand. So any one of those nerve roots coming from the cervical spine, if those are involved, that could potentially lead you to somewhere in the hand or wrist to have some numbness or tingling. If you're looking more at a local spot for where the hand can have a problem, most of you have probably heard of the term carpal tunnel syndrome. So that was definitely one of the more common areas. So if you remember from your anatomy class, you have all these things going through this carpal tunnel, including one nerve. And so if there becomes too much pressure or becomes compressed somehow from doing repetitive motion, you can end up compressing the nerve. Well, that nerve would be median nerve. So if a patient's complaining of kind of thumb, pointer finger, middle finger numbness and tingling, that may match up with kind of median nerve. Versus if a patient's complaining of fourth and fifth digit numbness and tingling, well, that doesn't match up with median nerve because that's the ulnar nerve distribution. So that would be, the site for that is more of the Guyon's canal. If you don't remember what Guyon's canal is, it's that nice canal between the pisiform and the hook of the hamate, and there's actually a nice kind of roof over it. And sometimes if you're doing a lot of compressive activities in your hand, or cyclists being on their bike a lot, this will be a site of compression, and then they'll start to get some numbness and tingling into those fourth and fifth digits. And then, as always, just like with the elbow, we kind of talked about already, is even if a patient's coming in with numbness and tingling in their hand, you can't rule out that it's not a cervical spine issue right off the bat. So you got to make sure you look at the cervical spine and then work your way down to the hand. Whew. That was kind of fun there, right? That was a lot of information thrown at you right away. But now we can kind of get into some of these other things. So hand surgeries in general, they're just way more complicated for sure because of all what we just talked about. You saw how complicated the anatomy is, so you can imagine how complicated the surgery would be and how difficult the rehab can be. That's why we have certified hand therapists that have to go through hours and hours and hours of extra education and mentorship in order to learn some of these things. Whereas we don't really have like a certified elbow specialist or something like that. It's just less complicated, and we don't do nearly as much function with the elbow as we do with the hands. So if you can imagine, if I were to take your hands and make them non-usable, it would probably affect your quality of life quite a lot. So that's why we try to have some people that can be specialists. You still have to be dangerous enough to be able to treat when you can, and then know when to refer out when it's above your abilities. But you should always be willing to take on the challenge if able, particularly if nobody else is around. Somebody has to see this patient. And then we can get into other disorders of the hand as well. So let's start with joint hypomobility. What can cause joint hypomobility? I feel like we've kind of covered this a few times now. What can cause it? Well, if you have an active inflammatory process going on, like rheumatoid arthritis, that can cause that swelling that's all in the joints. That can definitely cause what would look like hypomobility. You have your degenerative joint diseases, osteoarthritis, post-traumatic arthrosis. If you had an injury and then it had to be immobilized for a while, you can get hypomobility from that. So we've seen these things before. And just to kind of remind you, right, rheumatoid arthritis, this is definitely one that will affect your patients. And you kind of saw I showed you what the person with their hand looks like before. This would be an example of that same thing. Of early rheumatoid arthritis, you may just see some pain, some swelling, some warmth, and a little bit of limited motion, particularly if it's in the active phase. You can also get some carpal tunnel syndrome because everything is swollen again, creating more pressure. And as you get more and more advanced on that right side of the picture, you get that later stage RA. Remember, so basically what happened is as it continues to swell in those acute phases, it stretches those capsules of those joints out and they become more and more lax, allowing them to have more and more deformities. And so usually what you end up seeing in a patient that has rheumatoid arthritis later on in their hand is you can see that ulnar drift of the fingers. You're going to see a swan neck deformity. You'll see some boutonniere deformities. You may see volar subluxations. You may see ulnar subluxations of the carpals. That ulnar drift, as I talked about, and then kind of the zigzag thumb deformity of the thumb. So when we kind of look into a little bit more what that means, you guys may have seen these pictures when you're in anatomy before. So the difference between kind of a mallet finger, a boutonniere deformity, and a swan neck deformity basically is what part of the things are involved. And we'll get into a little bit more, but since I'm here for a little, let's talk about a swan neck deformity. So looking at that bottom picture there. So in the swan neck deformity, you're going to have laxity, and I'm going over these specifically because the board exam loves these questions. So pay attention here. The book does a good job of explaining it as well. So if you can figure these things out, it will really help you figure out what the anatomy of that extensor hood and that extensor mechanism. I should be more specific. Extensor mechanism is. So with a swan neck deformity, you can have laxity of the PIP with an overstretched volar palmar plate. And so what that causes is it causes bowstringing of the lateral bands in the extensor hood. And when that happens, it leads to hyperextension. Here's the key part. It's going to look like hyperextension of the PIP and flexion of the DIP. And basically what ends up happening is you have these tight interosseous muscles pulling on the extensor tendon that reinforces the hyperextension of the PIP. So a swan neck deformity is going to have hyperextended PIP with a flexion of the DIP versus the boutonniere deformity. Now what the boutonniere is that's a stretching or rupture of the central band, known as central slit. That's one of the things you probably should remember. Probably a good test question, hint, hint, wink, wink, of the extensor hood. So I have the central slip of the extensor hood, which results in the lateral bands of the extensor hood migrating volarly, which causes the PIP to go into flexion and then the DIP to go into extension. So, swan neck and boutonniere deformities, they're both hand deformities, but one is flexion, hyperflexion at the PIP, and the other one is extension at the PIP, and then the reverse of that happens at the DIP. So if you can get a hold of that, that will help you out a lot. I can almost guarantee there will be a question or two on the board exam of that mechanism. We also know that osteoarthritis can cause hypomobility. Again, in the acute phase of osteoarthritis or in that early one, we're going to hear complaints of achiness, stiffness, swelling, warmth after stressful activities, kind of a warming effect of the hand. It's just really stiff in the morning for about a little less than an hour. And then in the advanced phases of osteoarthritis, that's when we can start to see the degeneration of the joint, which can lead to capsular laxity, which can lead to hypomobility or instability, which can lead to contractures, muscle weakness, weakened grip. Makes sense, right? As I can use my hand less and less, everything else is going to kind of fatigue or atrophy out, and you'll end up getting weaknesses and decreased grip strength and things of that nature. Additionally, we can have that post-immobilization. So like after a fracture, we may have to put somebody in a position of immobilization. So what we need to be alert about is sometimes after fracture, right, by the time you get the blood flow into the wrist and hand, particularly of the scaphoid, like that mechanism of injury where you fall on the outside of your hand, people are like, oh, you broke your wrist, let's work on that. You broke your elbow, okay, let's immobilize you there. But well, some things you can do is sometimes you actually will disrupt the blood flow. Again, it's particularly to the scaphoid, but it can happen in other areas as well. And so after the injury, you go get the X-ray, they see the fracture, and they're like, oh yeah, you broke your elbow, broke your distal wrist, perfect. Let's put you in a cast, and we're good to go. And then you may actually notice that um, the ability to read a fracture in the hand is much, much harder because everything is much smaller and they kind of overlap, and it's just hard to get a clear picture of that. Or sometimes what can happen is the vascular supply actually gets disrupted, and then you're going to get necrosis a little bit later. So sometimes if a patient has come, I've actually had this happen to me a couple times where a patient came in with a complaint of a fracture of something, and then as I was working with them, they started having complaints of hand pain more frequently, or having more sensitivity in that snuff box, right? That's where that scaphoid is. And then I'm like, you know what? This doesn't make sense. You should be healing at this point from a bone healing standpoint. And send them back for the X-ray, and then they've had some necrosis of some of the bones, so that vascular supply was diminished. So they had to go get a surgery to help repair that stuff. So what you're looking for is with the signs and symptoms of that, you may see some swelling, increased sensitivity to tenderness to palpation where it wasn't quite as tender before, some muscle spasms when passive motion is attempted because it's trying to protect you. And then increased pain whenever the bone that was injured was stressed. So those are some things you got to keep your eye on for that are a little bit more common in the hand than they are elsewhere. Again, just because the vascular supply is by the time it gets to the hand is so small compared to what it looks like when it's at the shoulder. And then the impairments you may see, right? Everything you do with your hands, ADLs, dressing, eating, gripping, driving, all those things can be impaired. So this one can be very involved and really take a patient out of what they normally do in their daily life. So it wouldn't be uncommon for you to see people that have these problems. They can develop depression relatively quickly because it's hard to do anything when you're so used to doing things with your hands. So what do we do? Well, we know how to kind of do these things already. We've talked about this. I hope you guys are picking up on a common theme here. We start with the protection phase. How long that varies and how long that lasts just depends on what the patient's presenting with the pathology. We know we need to control pain, protect joints when we have to, maintain joint integrity and tendon mobility to the best of our ability, work on muscle integrity. So we definitely know that if a patient is in an active state of rheumatoid arthritis, we're probably not going to do joint mobs, right? That makes sense. We may we can work on some balance stuff, or we may have to rest the hand. Most of the time this mechanism is that somebody fell, and so we can work on balance where we don't do anything with the hand. In addition to that, we may start to work towards the controlled phase after that, where we're working on increasing the joint play and accessory motions, working on joint tracking, pain-free motion, improved mobility, strength, function, all the things that we've talked about before that we do in the controlled phase or that subacute phase. And that's when you can kind of add in the mobilizations with movement. I find that to be super effective for people that are having wrist or hand problems, and we'll go over a little bit in those in lab as well. We could talk about radial, with mobilizations movement. One of my favorite ones is doing a radial glide to the proximal row of the carpals to work with wrist flexion or extension, And if we have too many imbalances in the hand, we can lead to deformities. So that's why we're trying to work on the mobility and strength of everything that needs to be mobile and strong in order to try to prevent the hand from having a deformity. Because if the hand has a deformity, you can imagine that the function is going to go down in your hand, and we do not want that. So your book again has your box 19.1 summarizes kind of joint protections for the wrists and hands. You can go back to chapter 5, which shows some of the joint mobilizations that we've talked about before. And then figure 19.7 has a nice illustration of what it looks like with a mobilization with movement. Sometimes, unfortunately, patients need surgery and at their hands. So indications for surgery, very, very similar to what we've talked about before. Sometimes it's just relieving pain. Sometimes it's restoring function or trying to just improve the function. Sometimes it's to correct an instability or a deformity like you see in patients that have rheumatoid arthritis. And sometimes it's to improve range of motion. Sometimes it's to improve the strength of the fingers and wrist for functional grips and tasks. And that's maybe when you saw like a tendon transfer. We'll talk about it a little bit more to try to help improve different things in different patient populations. So the first one we're going to talk about is wrist arthroplasty. Arthro meaning joint, plasty meaning replace, right? We're replacing the wrist joint. You won't see it that often compared to what you'll see for the shoulder or knee or hip, but they're out there. So it just depends on what setting you want to work in and kind of almost where you're working as well. And with this surgery, the indication generally you'll see people is there'll be severe pain, a lot of deformity. They may see some subluxations, or to try to improve function. And when you're thinking about our replacements, similar to what we talked about before, our contraindication for getting this surgery would be if you're trying to get back to high demand use of this hand. If you had ruptures to the wrist extensors, or if you had neurological damage to the hand. Basically, if we can't use the we shouldn't do surgery to it, for at least replace the wrist joint. If even if I replace the wrist joint and I physically can't use my hand after that because of nerve damage or no muscle function, then there'd be no point to do that. A kind of a precaution, we definitely want to be careful of kind of we saw at the elbow is we don't want to do a lot of weight bearing on that hand during transfers and ambulation. So we may have to won't be able to do necessarily like slide board transfers, or maybe we got to be a little cautious if we're using walkers, or maybe we have to, instead of doing a rolling walker, maybe we have to do more of a platform walker so the weight goes through the elbow for these patients. And then we definitely don't want the hand to be come too lax, because we talked about how stable that hand is. And so we're not going to really pick things up that are more than 5 to 10 pounds, because we don't want to pull those prostheses apart and wreck it. And generally when we, after the surgery for the immobilization, we talked about with the grip, how grip is better if you have a little bit of wrist extension. So generally when you immobilize these patients, you're going to put them in about 10 to 15 degrees of extension. That way they have a little bit more function of their hand even while their wrist is immobilized. And again, we had the joint replacement. The point of the surgery was for function, not necessarily full range of motion. So my goals will not be let's get back to normal flexion, extension, only deviation, radial deviation. I want that wrist to be functional. So I'm going to prioritize stability of this over mobility. So an example would be reality, and for these patients, if we think of our total arc that we have now, right, we got about 70 degrees of wrist extension, 80 degrees of wrist flexion, so you're looking like 160 degrees of total arc-ish. The total arc we're looking for after a wrist replacement, maybe 60 to 90 degrees total of flexion and extension. Again, we don't really care about mobility as much, we care about stability and function. And then when it comes to radial and ulnar deviation, we're only looking for about a total arc of 20 to 45. And you'll get those kind of, if you ever see a patient with this, you'll kind of, how do you know? You ask the surgeon what they had after the surgery, because remember, they're going to, once they replace it, they move their hands to see what they can get. And then that's the top end that I would ever try to get that patient back to. We're going to prioritize function and stability over mobility. So what that kind of looks like here is just like we saw with the other joint replacements. This would be a total wrist replacement because we're doing both sides. And you can see how crazy that is to try to stabilize some of that plate and what it looks like. And so there's different ways you can kind of do that. What they're talking about is there's different types of prosthesis. You'll see the middle one has kind of the concave convex versus the picture C there. Looks like it just has two screws and one side is concave. So there'll be different reasons of different surgeons use different things. When we look at kind of the outcomes we have with patients that undergo these things, again, maybe the goal is really is pain relief, function, and stability. We're not as worried about range of motion at the wrist itself. And then there's a lot of complications that can come from these things, from your normal ones such as infection, or if we move them too much too soon, loosening. And so you have to be cautious enough with these patients in order to make sure we're not compromising what the goal of the surgery was. And again, your book does a lot. I believe it's box 19.3 has some nice precautions after you undergo wrist arthroplasty. So review that if you want to know a little bit more. Okay, now we're going to move on into the hand here a little bit more. So we can have a metacarpophalangeal, so your MCP, implant arthroplasty. Wait, you can replace your finger joint? What? I know, right? It's crazy. But what would the indications of surgery be? The same thing we've seen before. Minimize pain, improve function. There was instability going on. Yeah, we need a little bit more range of motion, or again, a hand deformity. So you can imagine, again, like folks that have rheumatoid arthritis when they're in that late stage, their whole hand has gotten crazy looking just from the degeneration that's happened. So this is actually often done for people at the late stages of RA to help improve the function of their hand. The key with this one is you have to have your extensor digitorum tendons intact, or you have to repair the tendons if you're going to do this, because you need those tendons in order to have these things work. And there's basically three types of implants, and your book does a good job of talking about them. But when it comes to the postoperative management, we're really looking at immobilization, right? They're going to be immobilized in these bulky compressions with a volar orthosis. The wrist is going to be in neutral, and the MP joint is going to be in full extension, or either neutral or slight radial deviation which is basically the reason they do that is because, remember, most of these at this point for the folks that are RA were an ulnar deviation, so they may pre-position them into radial deviation to combat that deformity. The position of immobilization is just, again, be based on why they're having this surgery. And then you usually have your distal PIP and DIP. You have your PIP and DIP are usually free rather than being brace itself. Then you're going to go into a little bit more of a dynamic splint after being immobilized, the dynamic splint's going to put you in about 10 to 15 degrees of extension with the MP joints in neutral and slight radial deviation. So what kind of exercise can we kind of do with these folks, right? Well, for exercise progression, well, with the MP flexion, that's usually going to plateau before the active motion of the MP, which is about 3 to 4 months compared to 1 year for the flexion versus the extension. And then with the small finger, so like with your ring finger, you may actually end up buddy taping that to another finger, and the buddy tape is just to help you use those two fingers together because it may be weak due to chronic subluxations of the MP. So, again, your book does a really good job of explaining this. So if you need to, I think the exercise progression is interesting. Not something I've ever done personally. I've never seen anybody that had this procedure done before. So definitely out of my realm, but I would love the opportunity if it ever came about. That's what it would look like under X-ray. You can see the joint had been replaced there. That had two of the fingers, and again, you may end up pre-positioning the immobilization based on trying to correct a deformity or improve function. So kind of continue down this road with the outcomes. They're actually relatively okay. Usually, again, the reason the patients are getting these surgeries are for improved hand function and pain relief, and that's usually why patients are satisfied. With the range of motion, again, I'm not necessarily saying I want full range of motion. If the problem was hypomobility, maybe I'm saying yes, I want a little bit there. And the hand function is priority. And then complications, just like with everything else, you got to watch out for infection or moving them too fast and the prosthesis failing, or you loosening up the cementation process a little bit more. So just watch out for those. All right, now you got your PIP joint replacement. Woohoo! All right, what do you think the indications for surgery are here? Can we guess they're going to be pain or loss of hand function or stiffness or deformity? Man, it seems like a common trend here. With the immobilization for these folks, again, we got to mobilize in position that will help improve the functions of the rest of their ability. So usually the wrist is going to be put at about 15 degrees of extension, and the MP joint is going to be in about 20 degrees. With that precaution, during range of motion exercises, we really want to make sure, if you think about that PIP, it only kind of flexes and extends. We really want to avoid the lateral and rotational stretches of the operated joint, because that could compromise the stability of that new prosthesis. And with our outcomes for these folks, basically we can generally get people back to about 45 to 70 degrees of flexion and then nearly full extension. Again, I would rather sacrifice mobility in this case for stability and hand function. So your book does a nice job of comparing the surgical approaches on table 19.2, and then you have some, this may be another surgery you may get if somebody has a boutonniere or a swan neck deformity that they want to have correct, and your book does a really good job actually giving you the guidelines and precautions for that box 19.4 and box 19.5. So now kind of moving on into the thumb, we can replace the thumb joint. Interesting. It just feel like any joint we have, we can do a little bit of replacement, right? So anytime you see arthroplasty, just know that you're replacing the joint. Arthro being joint. Using those Latin terms. Why can't we use Latin anymore, huh? Why didn't any country speak that? I could be so much better at these medical terminology. Anyway, that's a rant. Moving on. Indication for surgery. Can you guess what the indications for surgery are to replace this joint? Yeah, I hear you there. Good job. Pain, instability, stiffness, or limited range of motion, decreased grip. There are a ton of things that can cause that, just like everything else that we've looked at before. With the background and surgical options, there are a lot of different options. At least 8 that I can find. And those options can include anything from going with you get a joint replacement and then you get ligament reconstruction, you get a joint replacement and then you get a bonectomy. They'll take out part of the trapezium, that'd be a trapeziectomy. You can get a full-on replacement. And then basically with your mobilization at this point, you're going to be in a little bit of palmar abduction, about 40 to 60 degrees. MP is going to be in slight flexion. Wrist is neutral to wrist is neutral to maybe slight extension. So the key with all these immobilization things, you guys, is you really got to think about not putting any of the things we're looking at in an overstretched position. We talked about that when you have a muscle injury versus a ligament injury versus a tendon injury. I don't want to put them in a position that is elongated unless I was trying to correct a deformity, when then I would position it into the position of elongation. So again, that would be an example of somebody that has that rheumatoid arthritis, that those late stages, they have those finger ulnarly drift, and then I would actually, when I cut, I'd actually pre-position it in a position of radial deviation. Or if a child with cerebral palsy has those tight heel cords or those tight Achilles, and I go in and I cut through the Achilles, then I would then put them in a position of elongation for immobilization. But most of the time, unless you're trying to do and correct that deformity, most of the time that you have a surgery, you're going to pre-position in a shortened position to allow whatever it is that you cut through to heal closer because it's in a shorter position. And then our outcomes generally are we have relatively good outcomes. It's about a 6 to 12 month recovery. It just depends on what you're trying to get back to doing. And then with our precaution, just like we talked about before, I would rather give up mobility in order for the stability of that replaced joint. So I will refrain from getting full CMC radial adduction as it stresses the dorsal part of the capsule in the ligament which had been reconstructed. And then I would avoid pinch or grasping for 3 months. So looking at those grips again, if you're pinch or grasp, just those positions of having that radial adduction position is going to stress out that part of the capsule we cut through to replace the joint. So again, your book does a really good job. Box 19.6 has the precautions after those. So if you're interested in that, take a look. The other thing we can kind of do is we can have tendon ruptures, and these are often associated with folks that have rheumatoid arthritis. Another reason you can end up having this would be if you have too many corticosteroid shots. We know that those degrade tendons, so you can actually potentially have a tendon rupture with that as well. When we think about which tendons are more affected, generally it's the extensor tendons that are more affected than the flexor tendons, and by that I mean it's almost always an extensor tendon. It'd be hard to get a flexor tendon. And the extensor pollicis longus is one of the more common ones when it comes to the extensors. And then if it does happen on the flexors, it's generally the flexor pollicis longus. So a lot of times it ends up being the one that's attached to the thumb. I'm not saying it can't happen on the other fingers as well. And generally the reason that you may get a tendon rupture, it will be from kind of a proliferation of the synovium in the tendon, abrasion or fraying, so kind of like chronic disuse, or sorry, chronic overuse. You're kind of taking a tendon, moving it over a bony prominence. Basically, that can start to erode. The tendon can start being eroded by synovitis and periodic use of those local steroids, like I was talking about. Another reason that this could kind of happen is if you have the ischemic, right, no blood flow necrosis leading to degeneration caused by direct pressure, that can happen. And most of the time that you'll kind of see these ruptures or the parts where the bony prominences can start to fray, the tendons are going to be the distal ulna, Lister's tubercle, and the volar aspect of the scaphoid, just because they can kind of end up coming to a point and they can start to shave down, if you will, that tendon and start to degenerate it. And then indications for this would be a rupture result for the surgery would be kind of a rupture resulting in loss of hand function. You can imagine if I lose the function of my hand, I want to do anything I can to kind of get that back. But you have to understand that just because you have one rupture doesn't necessarily mean it'll be a loss of function of the hand. Just depends on what got ruptured. So just because something gets ruptured in the hand doesn't necessarily mean we'll go in and we will fix it. With our procedures, you can do a couple different things. So tendon transfer, sometimes they do this, we talked about this already with kids with cerebral palsy. Generally, they're kind of stuck in that wrist flexion, finger flex position. So what they'll do actually is they'll take the flexor tendon and they will actually then put it onto the extensor side. And so that flexor tendon becomes an extensor tendon to try to help this child kind of use their hand a little bit more. Just know that you may use a tendon graft reconstruction. The palmaris longus tendon is often used to be the thing that replaces whatever tendon was ruptured. With folks that have rheumatoid arthritis, you got to remember that there's a lot of degeneration that's going to happen. So if you're going to then take a tendon to become a graft, there's rarely where we can use a direct end-to-end stitching. So you take the new tendon and then the old tendon and stitch them together. You can rarely do the direct end-to-end portion because the tendon is generally frayed from what was there. So they end up usually cutting part of it, make it a nice, less frayed tendon, and then they stitch it together there. And with the post-operative things, with the immobilization, generally these folks are going to be positioned in about 30 to 40 degrees of wrist extension, right? Usually it's extender tendons. We put the wrist in extension to allow it to be in a shortened position to heal a little bit better. and then the MPs we usually have are in a little bit of flexion with the IPs being free. And the reason you can do that is we know with that wrist extension, we're putting the slack with everything on slack. When we go into MP flexion, it's not putting on enough to stretch it out, and we can still have some function of our hand. Um, the outcomes generally, we're gonna have slower healing processes if we have a systemic disease such as rheumatoid arthritis, and the outcome is really going to depend on the quality of the underlying tissue. If it's super degenerated, it's probably not going to be a really good outcome. If it's rather healthy tissue, probably have a better outcome that way. And then with the precaution, it's basically with these folks, right? We don't want to. We just had a tendon rupture. We don't want to stretch anything because we don't want to tear the tendon stitches that we just had. So we usually are going to postpone stretching, and then we want to avoid a combination of finger flexion or thumb radial abduction and radial adduction with wrist flexion. And again, the reason for that is we just don't want to put too much pressure on those reconstructed tendons, and so we avoid kind of excessive gripping if we can. So again, your book has a nice little box in there. If you have a little bit of need a little more clarity, it's box 19.7 if I'm correct. So other than having the traumatic, crazy stuff where tendons get ruptured or we got to replace joints, we can have your more common things like your repetitive traumas and overuse syndrome. So again, we can have a tendinopathy, tendon, meaning we know it's in the tendon. Opathy, we're having that pain in there. We have to figure out is this an itis or an osis kind of thing. So we know that tendinopathy is basically a pathological breakdown of the tendon structures that results from repetitive use. Common impairments, basically patients are going to complain that when they go to use that tendon, when they contract that muscle that pulls on that tendon, we get pain. We know it could be potentially in that itis phase, so we may see some warmth. It's probably going to be tender to palpation. There'll be an imbalance in muscle length and strength, or poor endurance of the stabilizing muscles because they're in that overuse position, right? I'm already overly fatigued? How can I then do more endurance-based things? With activity limitations, we may see folks that have kind of inability to perform repetitive or sustained work. So again, you're typing or kind of working with your hands, working with screwdrivers, hammers would be another reason. Nice part is with our management, we kind of go through our normal phases. We go through the protection phase. So in the protection phase, we want to make sure that we promote tendon mobility, right? We're getting that transverse friction massage while the tendon is in an elongated position so that the mobility develops between the tendon and the sheath. We can teach stretching and tendon gliding exercises to the patient. We want that tendon to slide and glide the way that it's supposed to, and we can work on the muscle integrity. So kind of your isometrics that we were doing before. When we work into the controlled phase, we may do more things like the dynamic exercises, look at biomechanical assessments. There may be some other problems in the wrists or hands that result from the poor stabilization of the shoulder or elbow, right? So elbow dysfunction or shoulder dysfunction could force me to use my hand in a way that it wasn't intended to, or kind of overuse my hand, and that could be why. So just because we're protecting, even we go back to protection phase, even if we're back in the protection phase and we have to protect the tendon itself, we may still be able to work on some of those postural muscles up top or the shoulder function or elbow function because that won't compromise the tendon that we're protecting down in the hand. So remember, the protection phase is local protection. You can still work on the things that are above or below depending on where you are to try to maintain or promote more function. And we see a lot of evidence on mobilization with movements, doing exercise, and transverse kind of friction massage for about 12 sessions. There's a nice little article that talks about if you do that mobilization, movement, exercise, different specific exercises, and transverse friction massage over 12 sessions. By session 3, most patients will report about a 50% reduction in symptoms, and then by the end of the 12th session, generally most folks are reporting somewhere between 0 to 1 out of 10 pain. So if you can kind of work on those things, then that's an easy way to start working if you have somebody that's presenting with a hand tendinopathy. We can also have some traumatic lesions of the wrist and the hand, so we can have something like a simple sprain. So in simple sprains, right? Sprains mean that we hit we stretched a ligament, right? You sprain a ligament, you strain a muscle. We're probably going to work on that non-operatively first. So um, the mechanism for this generally is traumatic, right? So it's usually that foosh or that fall in the outstretched hand, or it could be excessive force on supporting ligaments, which may have related fractures or subluxations or dislocations. So the signs and symptoms patients will normally complain about are pain at the site of where the force was, and then they may also demonstrate we've stretched those ligaments out, right? So they may have some hypermobility or instability. You can refer back to, for the management, you can kind of refer back to the chapter 10 for guidelines on how to follow and managing acute lesions. And because our management is basically going to follow our normal tissue healing times, and we follow the appropriate stages: acute, subacute, chronic. And you guys have, I think we've beaten that into nauseum, the type of things that you can do. This is where it gets fun. I can guarantee you, I would guarantee you that within the next couple slides there will be a board exam question on these, because they always seem to pop up. And even when I took my OCS exam, there's some hand questions that were on these things. So now we get into the lacerated flexor tendons of the hand, right? Lacerated being it's cut through. So your book does a really good job in box 19.8 and 19.9 about kind of outlining these zones for you. So the key with lacerations, when I think about it this way: you're holding a knife, somebody pulls it, cuts through your hand. You can imagine you cut through a bunch of different stuff, and you're going to lose the function of your hand. Well, we can't do that. So lacerations basically cause immediate loss of function of your hands. When we look at the volar side first, let's take the volar side first. The volar side of your hand is divided into 5 zones, and then your thumb is divided up into 3 zones. And the reason that they do that is because based on where that laceration is, your rehab or your ability to repair something, or your ability to repair at all, is going to be dictated by. So when you're looking at that picture, there's going to be a thing. I'll pull it up here now. Here's kind of those zones. So zone 2, you'll notice, is called no man's land. And the reason why it's called no man's land is because there's like no vascular supply here whatsoever, and it's a very confined space. So there's nothing really to create a healing aspect. So if you have a laceration up in no man's land, basically they just leave it alone, because doing surgery doesn't seem to do a whole lot. If they do surgery there, just the healing tissues are prone to getting excursion or movement restricting adhesions. So sometimes actually doing surgery there causes more hand dysfunction than not doing surgery there. With the types of repairs, there's direct repairs versus other types of repairs. With a direct repair, if you have a straight laceration, so if the laceration is directly across, they can do a direct repair. If you have more of a jagged laceration, then they usually have to do a tendon graft, because now you don't have equal parts of that tendon to kind of stitch back to, or that tendon to kind of stitch back together. So additionally, the timing is very important for after I get my laceration. How quickly can I get this done? And the timing is important because the severed ends of the tendon begin to soften and deteriorate very, very quickly, and the proximal portions retract. So if the earlier you can get there, the healthier the tissue is, and the more where it's supposed to be makes it much easier to repair. So if we can get it between, day 0, if you will, to 10 days, they usually are going to have pretty good results. If we delay it over 2 weeks, right, so we allow those tendons to deteriorate, we've allowed them to retract, so the cut, if you will, is much larger now, we have relatively poor outcomes. So Definitely something that is going to be asked about, knowing these between the volar side and the dorsal side. Your book does a really good job illustrating these pictures and giving you some more background on those things. So definitely check that out. When it comes to the timing of the repair, it's really kind of, we look at those things of basically just staging. Is it immediate, delayed, secondary, late, or staged? When you're like, well, why would, if it's lacerated, why would I wait? Why we just said that it's better if I get it done earlier. You're right, it is. However, not all lacerations are nice and clean. You may have fallen and had your hand cut on a piece of barbed wire and you got tetanus, right? Well, they're probably not going to do these things. So you may end up delaying the repair if the wound isn't clean, if you have multiple other injuries where those other injuries take priority over your hand. If there's a lot of skin loss or you have unstable fractures, that may be another reason I have to delay where I am. Or if you have tendon pulley damage, then we may end up having to have multiple surgeries over weeks and months in order to try to get the best hand function that we can. So even though it makes sense we should repair as quickly as we can, sometimes we can't. And sometimes if things are way too swollen, we know that swelling degrades tendons as well. It's much harder to cut something or to repair something if it's super swollen, so we may have delaying until some of the swelling goes down. So not our call, obviously. This is usually the surgeon's call, but just kind of important to know that if someone were to show up to you and be like, I cut my hand, what should I do? It's, all right, go to the doctor and let's see what they think. Is it a clean cut or not, and do we need to get the swelling down? When we kind of look at what the laceration ends up looking like, you'll notice in this picture you got kind of this Z-shaped stitching. And the reason they kind of do the zigzag approach is because it actually will preserve the function of the sheets better than if you did a straight vertical cut. And what's also interesting about this, when they look at the cut, you actually look at the suturing technique, and the number of suture strands that they have will influence the initial strength of the repair. So they try to do as many as they can, but not overloading it to where they're gonna make everything go south. And then there's going to be a period of mobilization. I do not want to stretch out any of those tissues. I need it to heal so that way we can get the function of our hand back. So kind of continue on the general considerations is our goal is really to try to prevent adhesions that we can to the best of our ability. Factors that kind of contribute to where more adhesions, basically the location of the injury, in the flexor zone, zone 2 of the hand, that's just that no man's land that tends to have a higher risk. And then on the flip side, the extensor side, usually zone 3 is the side that usually has more risk. The more trauma there is, the more likely there are to be adhesions, the more reduced blood supply there is. So that's why that no man's land has a higher risk. Excessive, if the surgeon's in there and they're handling the tissue a lot, the more they kind of roll the tissue around, the more likely the surgeon will cause adhesions to happen. If they don't do a very good job stitching, ineffective suturing technique can lead to more adhesions, damage or resection of components of the tendon sheath. So again, if we waited too long and that it retracted back, then it's going to scar down in that retracted position and create an adhesion. If we put people immobilized for too long, or if we get the repair due to excessive stretch. So if we overly stretch the new thing that was repaired and stretch it out, and you create that gap, that's going to scar down and create an adhesion right there against the bone that's underneath it. So in our early and general considerations, we really want to work on early controlled motions versus delayed motions. So when do we want to do delayed versus when do we want to do early? It's basically how they're kind of classified in. So if we want delayed motions, generally the reason we would pick a patient to have delayed motions is this may be somebody who can't actively participate in rehabilitation. And that could be something like children, where they don't really, under 5, they don't really understand that they shouldn't be doing things. So that's usually when they will mobilize them for longer. They may have diminished cognitive ability or capacity, unable to adhere to the program. Maybe people are unmotivated. Maybe they're just super aggressive, or maybe they have other injuries. That may be a reason that we choose not to let this person move in the earlier phase. Versus with the early people, that the ones that we want to do early controlled motion, the thought is that if you can do a little bit of active range of motion in a specific direction that pulls on the tendon, we may be able to decrease the adhesions. That's when you're trying to do the slide and glide. That's going back to like that tendinopathy, why even in the acute phase, we may be doing some cross friction massage because we want that tendon to slide and glide, and we can do these tendon mobility drills. We can do some, in the early control motions, we can do some place and hold techniques. We can use some dynamic approach. We can also use a little bit of combined, which is or the Groth combined approach for this, which is basically a criterion-based progression for optimal tendon loading. We may get to the max protection phase, right? Once we're there, we want to maintain that MP joint inflection during passive range of motion of the IP joint to avoid excessive stress on the repair site. Remember, in max protection, we don't want to stretch out the repair site. And evidence will tell us, or research will kind of tell us that it's preferable to perform place and hold exercises with the wrist in extension and MP's in flexion, because the flexor digitorum superficialis and the flexor and the digitorum flexor digitorum profundus have the least amount of contraction force there. So again, place and hold exercises in a specific position will cause less contraction force than other positions. Important to know that in order not to overload the repair and cause it to tear. Once we get to the moderate protection phase, we could do more place and hold exercises with more force. We can do a little bit more active range of motion. We can work on tendon gliding a little bit more, and then we can. We're still going to kind of avoid combined wrist extension and finger extension for about 6 to 8 weeks, and that would be in particular for something that's repaired on the flexor side, right? Because if we're going to wrist extension and finger extension, we have stretched out that flexor side as much as we possibly can. We want to wait till it's a little bit more matured in that 6 to 8 week part. And then again, depending on where the surgery was, what zone was repaired, we have about 80% of our outcomes are good to excellent, just depending on the area and then if they were able to engage in the early motion program or not. So again, your book does a really good job, anywhere between like box 1910 to box 19.4 or 1914 has a really good illustration of that, and then so do some of your figures that are there as well. So that's kind of to splinter protect tendon repairs. Again, this would be if you have more of that flexor tendon repair. Wrist is in slight extension because we want that more functional position, but then the fingers are in that flex position in order to keep that flexor tendon in a more slacked position. And then here's kind of the nice way you can look at exercises of the hand, and going from the bottom is the most protected you could possibly be to the top where you're in the most resisted kind of position that you can. So there's a nice little that Groth combined progression, and then there's reasons that you start to move from one to the next. But just kind of give you a picture of what that would look like. All right, moving on. We're going to the other side of the hand here. So this would be the dorsal side, and you got to know box 19.6. You got to know it. On this side, it's actually considered less serious to have a laceration on the dorsal side than it is on the volar side. The extensor tendons are generally compared to the flexor side. The extensor tendons are actually thinner and flatter than the flexors, so it becomes easier to rupture. But again, there's so many back there, and we don't grip a lot from the back side, if you will, so it's just considered less serious than the flexor side. When comparing the volar to the dorsal side has 7 zones, with the thumb of the dorsal side of the thumb has 4 zones. So if you kind of break it down when you're looking at the zones on the posterior side, the odd numbers are the joints, and the even numbers are the bones. That may kind of help you figure out where you are. Zones 3 and Zone 7 pose the greatest surgical threat and rehab challenges, basically just due to what's underneath it. You got the 3s, you kind of got that extensor hood there, and then 7, you're kind of getting into that carpal tunnel. You got to be careful about that. The most common zone that people injure would be Zone 5. And reason for that is it's kind of where your MCPs are. So if you ever punched anything, like you end up getting like a boxer fracture where you fracture that fifth metacarpal, that's generally in that zone. So that's just easiest to get an injury in that zone. And you can get an extensor tendon there if people were to bite your hand. That's where they usually end up tending to bite. It's called fight bite, interestingly enough. And if you get a fight bite, somebody bites your hand and you tear your tendon, there's a high risk for infection and becoming septic because you never know what's in people's mouths. So let's not do that. Or same thing if an animal were to bite you in the hand, that's usually where they bite you. So it's just an interesting term, fight bite. Your book actually will talk about it, so fun to read about that a little bit. With the extensors compared to the flexors, there's a lot more soft tissue attachments if you think about that whole extensor mechanism of how it happens. So if you were to get an extensor tendon rupture, there's less retraction on this side because of how many things it attaches to. Compared to the flexor side, you can get a lot more retraction because there's not as many things the flexor tendon is attached to. And then going back to that one of those first pages we talked about with mallet finger. So what is mallet finger? Mallet finger is actually a closed rupture of the terminal extensor tendon in zone 1 from forceful hyperextension. So a lot of times people get this from like basketball players will get this a lot because the basketball's coming at them real quick and it shoves their finger into that hyperextension position and it ruptures their extensor tendon. I think I have a picture of that. Yeah, there we go. Boom, there you go. Perfect, mallet finger. You got the sudden force of the basketball coming through. It presses the DIP joint back and ruptures the extension tendon. And then the last joint becomes swollen and the finger can't extend fully. And the reason they can't extend fully is because you ruptured your extensor tendon. Hard to then bring your foot, lift your finger back up if you cannot bring it up. A lot of times people won't repair it unless it becomes super involving and invading your ability to function. So if they are going to repair it, what you'll notice for the mallet finger, but if you go back to just an extensor tendon, if you are going to repair that, usually they do it with a repair or reconstruction. And just like the flexor side, they may do a initial or a delayed or a combo. Just depends on what is involved and about how quickly the surgery is done. So again, your book does a really good job of kind of outlining kind of the consequences if you injure your dorsal structure of your hand. I actually thought that box was very interesting. That would be box 19.16, and then you can review your anatomy, if you will. Probably a good idea. We'll do it in lab a little bit too, but we're going to be looking at box 19.15 as well. All right, so we talked about mobilization stuff. So again, this is going off of the extensor tendon. So general idea that we have is we want to prevent adhesions, and the adhesions are generally more likely on the extensor side than the flexor side because the extensor tendons again are thinner and flatter and have more attachment sites. There's just more opportunity to have adhesions. But our mobilization, basically, we're going to mobilize a person in extension because we don't want them to get into flexion. And our exercises that we kind of work on is we have minimum active tension early, right? So I don't really let people go into active tension. And we'll work on range of motion when we get to the second phase, and then we'll work on strength in the third. That usually occurs around 8 to 12 weeks, and then we'll work on gripping around 10 to 12 weeks or so. Your book does a good job of kind of outlining what a general rehab would look like. So moving on to the fun stuff, the exercises. We're going to go through a lot of these in lab. I think the tendon sliding, gliding stuff is really interesting, and we'll kind of work on those for sure. But now for something completely random, just because I got to break this up here a little bit. Which U.S. president supposedly became stuck in the White House bathtub? Actually, supposedly it was on his inauguration night. That would be President Taft. He's a fun-looking guy. Um, Next question: how many presidents died on July 4th? Actually, there's three of them. Two of them actually died on the same exact day. They were kind of rivals, John Adams and Thomas Jefferson, 1826. I always thought that was interesting. I believe Adams was dying. He ended up writing Thomas. They had a bet who was going to live longer than the other one. He actually wrote a note to Thomas Jefferson congratulating him on winning. And as the note was being, horse and carriage, so as the letter was working its way to Thomas Jefferson, actually Jefferson died prior to receiving the letter and prior to Adams. So actually Adams ended up winning, even though he went to the grave thinking he didn't. And then James Monroe would be the other one. He was 1831. So those early presidents, man, they just super loved freedom or independence. I don't know. That July 4th was the place to go. And then, which is the state of the birthplace of the most U.S. presidents? Now, I'm talking about birthplace, not which states claim some other presidents. So, sorry, Ohio, you don't have the birthplace of everybody. You have people that you try to claim, but not everybody was born there. It'd actually be Virginia. Virginia would have the most. They had Washington, Jefferson, Madison, Monroe, William Henry Henderson, John Tyler, Zachary Taylor, Woodrow Wilson. So they have 8. Go Virginia. That's my home state. So also fun fact, not on there, but why is Virginia known as the state for lovers? Like, why is Virginia for lovers? Because back in the day, it was the only state in the U.S. that you could, young people, 16-year-olds, could get married without their parental consent. Instead of being 18, so 16-year-olds would run away from Virginia. That's why it was for lovers. So don't say you didn't learn something from this lecture. All right, moving on to the tendon gliding and sliding stuff. So these are actually really cool, and if you can understand why these work, that means you have a really good grasp on what that extensor mechanism and what the muscles do and those things. So basically what you're looking at is we could do some place and hold exercises, which you basically put the patient in a position and have them just hold that. And then we can also work on the flexor tendon gliding exercises, which is what we're going to look at more so here. So basically, if you look at all these things, it tells you what positions to kind of go into and why you're kind of doing it. But basically what it looks like is you start with A and you work your way to D, and then you unwind. You go from E to D to C to B to A. And when you're doing that, you're making the most gliding of the flexor tendons we can. So if you're really trying to prevent adhesions and it's appropriate to do all this movement, this is a great way to make sure that those tendons are doing as much as they possibly can, prevent the adhesions, and that will make sure that you be able to maintain that good grip and keep that hand function going. So after the tendon gliding exercises, we can get to the tendon blocking exercises. With the flexor blocking exercises, we're going to work on some isolated things. We're going to isolate the MCP flexion. That will force you to work the lumbricals and the palmaris. We can do PIP flexion, DIP flexion. That will work the flexor distal superficialis or flexor distal profundus, or we can kind of do a full fist. And the reason that we're doing these things it's a little bit more advanced, so it's not going to be until the controlled or kind of that subacute phase, because you're increasing the stress on that flexor tendon that we just repaired. But basically what you can do is, if you want to work on the MCP, you just bring the MCP up into flexion. If you want to work on that PIP flexion, you kind of block the other fingers from going, and then you bend that up to flex at the PIP, or you can work on the DIP. So depending on what part you want to work on, you can. Your job is to block the other fingers and then joint just proximal to what you're looking for in order to really stress that tendon. But now you can see why, because it's stressing that tendon more right there. We want to make sure that you're in the position where we're allowed to do that motion. So that's not in the protection phase. It's generally more in that controlled phase. Kind of continuing on, we can get into exercises to kind of that reduce the extensor lag. So extensor lag, that's generally due to either some weakness of the extensors or you have some adhesions that are preventing it. And we can work on the same thing. It can either be at the MCP, the PIP, the DIP. It can be at the terminal ranges of any of the IP joint, and then we can do the gliding tendons itself. So with the extensor gliding exercises, basically what we're looking at is it almost looks like the Longhorn side if you're a Texas fan at all. And then you kind of working and getting to extension, and it promotes isolated control of the extensor indices and extensor minimi, and promotes their gliding on the tendons that they have. Your book actually does a really good job at figure 19, 17, 19, 19, 19, 20 of kind of showing you what some of these things look like, so feel free to refer to that section if you're wondering like what the heck I'm talking about. Now we're into kind of the scar tissue mobilization for tissue adhesions. So unfortunately, sometimes adhesion or tendon adhesions will happen. Things are going to get stuck down to the things that happened before them. So if that's the case, we want to make sure that we're trying to mobilize the long finger flexor tendons to the best of our ability. We can actually put them on stretch and add friction massage and then do the gliding, because we're trying to undo that adhesion with our friction massage. And we can actually add contraction at the top to stretch for that loading principle. And then same thing for the extensor side is we can put them on stretch and add a friction massage and then do the gliding and add a contraction at the top to stretch for the loading. So again, the whole purpose of this is you have this adhesion. It's kind of keeping you from limiting your range of motion. So you actually put that tendon on as much stretch as you possibly can. And then you do a friction massage there to break up that adhesion. And then at the top, you add a little bit of contraction, that kind of that contract relax to get that length back in the tendon. And so you can imagine that this is not something that we're doing in the protection phase, more so something we're doing in the controlled or the return to sport kind of things. Well, we want return to sport activities. We want to be cautious here a little bit with the extensor as the extensor lag. If the extensor lag increases after you do these things, then the tendon distal to the adhesion rather than the adhesion itself may be stretching. So even though you're thinking, yeah, I'm working on that adhesion, I'm stretching that adhesion, we know sometimes if you have an area of hypomobility, you may get a little bit more stretch or hypermobility at the places above or below it. So if there have, let's say extensor lag of 10 degrees, you work on the adhesion stretch, and I got an extensor lag of 15 degrees, you've made them worse. So we do not want to stretch, but we may still do the friction massage instead. So sometimes if we put them on that stretch position, do the friction massage, we actually don't get the adhesion to move. We got the distal portion of that sheath. So if that's the case, you take the stretch out and you still do the friction massage to try to break up that adhesion. So with stretching techniques, before stretching any of these tendons, we want to make sure that the goal of these would be to improve flexibility and range of motion. So before doing any of these stretches, we want to make sure that there's normal gliding of the joint surfaces. We want to be sure that if we're working on the wrist, we want to be sure that the fingers are free so we don't limit the range of motion that we have. So an example would be, again, if you are going to go into wrist extension, if I'm really trying to stretch out the wrist extenders, wrist flexors, I want to let the fingers go free because I can get more range of motion out of my wrist. If I actually keep my fingers in extension and then try to stretch, I'm going to get less, which now I'm adding in a little bit more hand limitation rather than wrist limitation. So you can kind of refer to your book. It's got some good pictures to work on ways to improve wrist extension versus wrist flexion and finger flexion versus extension of kind of the whole hand, or kind of working on it as individual joints as well. So kind of working on if we want to stretch the hand muscles themselves, working on those intrinsic and other multi-joint muscles, we could do some self-stretching to the lumbricals and interossei. We could do just to the interossei, we could do adductor pollicis, manual stretching of other intrinsic muscles, self-stretching, lumbar stuff. We're going to go over these a little bit in lab, but your book also has some good pictures of how to do that, just to kind of give you an idea. This will be a way that we can kind of walk through some of those other exercises. Again, we'll go through these things in lab. We'll show you how to stretch out some of those things, and then you have to understand what the precaution would be to stretching out one of those in particular if something was surgically fixated, or which tendon sheath is kind of off. And we want to try to develop, right, we know that end range rehab, we got to work on improving that performance and motor control and coordination of the movement. So there's a lot of different techniques we can use to kind of strengthen the muscles of the wrist. We want to work on the wrist musculature. We want to work on the weak intrinsic musculature. We want to work on the weak extrinsic musculature. And then we want to work on mechanical resistance of combined intrinsic, extrinsic functions, more of those gripping kind of tasks. So we can do things like with the intrinsic muscles, right? Those ones that are in the hand. We can work with like rubber bands as an example to help work on those lumbricals, dorsal and volar interossei, your abductor pollicis longus and brevis, and your opponents. Those would be considered your intrinsic hand muscles. Versus your extrinsic ones, we may be working on the eccentric digitorum, eccentric digitorum indicis, dicti minimi, IP flexor digitorum profundus or superficialis. We can start to do some towel curls, kind of like you've seen with the foot where they do the toe curls. We can do some towel curls, and that's the kind of combined way you can get intrinsic and extrinsic working together. We may use some putties or bands or grippers or springs. It just depends on what we're kind of working on. And then you can add in some wrist motions as well as you're doing the same things in order to get more combined motion as well. Your book has a lot of really good descriptions of how to do this. It's usually in your figures 19.23 and 19.26 will be a good place to reference for that. And then again, towards the end, now that we got kind of the gross function, we really want to work on getting that dexterity back. So working on fine finger dexterity, picking things up, twisting, buttoning, tying strings, etc. And then working towards functional activities. So that's your end phase of rehab. What is the goal that the patient wants to get back to? Let's start practicing those things, knowing that obviously with some of the progressions, the larger the thing is that you want to pick up for fine dexterity, it's easier. The smaller the thing gets, then it becomes more and more challenging. So you can use that to your advantage to help start to set up success for your patients as they get to the end of their rehab. So that's it, guys. It's not oftentimes that we like to think that we can kind of hand off our patients to maybe somebody who has a little more experience with us when it comes to the hand. Maybe if we have a certified hand therapist or an occupational therapist at our disposal. Not everybody does, not every hospital does, not every place does. So you may be in charge of treating these patients, and the reason I think that people get scared of it is the anatomy is challenging. It's a lot of stuff in a very, very small space. There's a lot of function that happens in your hand. So if you're not comfortable treating a patient with that and they don't get a whole lot of function in their hand back, it may make you not feel so good about yourself. But I think you can do it if you get a little more comfortable with the anatomy. It always comes back to get you for sure with that anatomy. I personally, I love this little cartoon because that's the only way I'm really gonna hurt my hand as much as I have, and that's usually what I tell my military guys. I said, "Oh, your hand hurts? Try shooting your weapon in the other direction." No, I don't do that. That'd be mean. Anyway, it's a lot of challenging stuff. We'll go over a lot of these things in lab again this coming week. You guys have been able to see how a lot of the joint mobilizations and exercises, how they kind of work. Should be able to start to see how they carry over into the hand from the elbow, from the shoulder. So if you have any questions, feel free to email me, and I will see you guys next week. Woohoo!